Well, we're going to start off tonight. My name is Steve Ludwig. I want to thank the Seattle Foundation for allowing us to participate in tonight's interesting case discussion. We're going to talk about very common fractures that we probably all see in our emergency room, regardless of what type of hospital practice you're involved with. But we all come across elderly odontoid fractures. And we're going to try and talk about some of the controversies that we all face with odontoid fractures. And then we're going to throw in the mix some other types of higher energy odontoid fractures, just to talk about some interesting associated injuries with them. We're going to start off with an overview of elderly odontoid fractures given by one of my partners, Dr. Dan Gelb. And this will be followed by 3 case presentations by our fellows. And then we can hopefully have some time in between the cases amongst all the panelists to discuss what they would do and some of the treatment pearls and wisdoms that we've all hopefully have acknowledged over the course of the past few years. And then we'll end with maybe some more open discussions if we have some time. So without further ado, I'm going to introduce Dr. Dan Gelb, one of my partners, to talk about the geriatric decision-making for odontoid fractures. Dan?
Thank you, Steve. So we'll move right into the talk here. There we go. So we're going to talk a little bit about risk factors of non-union and odontoid, which plays heavily into our thinking when it comes to taking care of the elderly. We'll talk a little bit about fixation, surgical fixation, and then some complications. Odontoid fractures are about 10 to 15% of cervical spine fractures, and there's a biphasic, as with most cervical spine injuries, there's a biphasic distribution. You see these young patients with high energy injuries in which men are more likely to have that type of injury than women. And then you have the elderly population where it can be extremely low energy injuries. They're often missed in the emergency room because they are such low energy injuries. Fall out of a chair, a stumble, and they're often an isolated injury as opposed to the polytrauma patient. And in this population, males outnumber females. The architecture of the odontoid really explains why we see these fractures in the elderly. As you can see in the picture here, as we age, the cortical the cancellous bone of the odontoid becomes thinner and thinner and quite sparse. And so really this becomes kind of an eggshell. And so it doesn't take very, very much trauma for us to see this type of injury. Even in this time, we are still mostly using the Anderson and D'Alonzo classification of odontoid fractures. Type 1s being fractures from the tip. Type 2 being across the waist of the odontoid or at the base, and the type 3 injury where the fracture line on the coronal film or the coronal CT reconstruction extends out into the C1, C2 joint. And the reason that that's important is because it gives you a much broader surface area for bony healing, and the rate of non-union in the type 3 fractures is less than in the others. And so as we get older and the odontoid fractures become more common, so do non-unions, and the risk factors for non-union are several. The most common ones that are cited are age, and here I put over 55, but I don't know that 55 is some magic number, and probably it's more of a continuous variable than it is a discrete time or discrete age. But certainly as people get older, the risk of non-union goes up. Displacement plays a role, as does angulation, as you can see in the picture on the right, where this fracture is both displaced anteriorly but also angulated. And then there's some question of whether how much instability is present, which may predispose to non-union, certainly, and loss of reduction in an immobilization device has been seen as a risk factor for non-union as well. So what are the treatment options? You have an elderly patient who comes to you with an odontoid fracture, and certainly historically or the Halo device has been used as the external immobilization of choice. But more and more, I think we're moving towards just use of a hard collar when we're not doing surgery. Anterior osteosynthesis has been popularized and plays a role, and then posterior C1C2 fusion, and we'll go over all these things. But here's a case, and I think it's illustrative. This was a man who came to see me. He's probably about 2 years now from his injury, but he's a 79-year-old man. He fell down, very typical story. He didn't show up to the emergency room for about 3 days, but he had neck pain, and appropriately they got a CT scan of his neck, and you can see he's got kind of a this is what I call a 2.5. On the right side, he's a type 2. His fracture doesn't exit out into the joint, but on the right side, on the left side, it's a type 3. It's minimally displaced and minimally angulated on the CT scan. This is his initial upright films, and I think it's difficult sometimes to see the odontoid itself, although if you look at the spinal laminar line, I think you can clearly see that there's some posterior displacement. And if you look at the anterior border of the C2 body here and the odontoid here, it's fairly displaced posteriorly. We had a long discussion with this gentleman. He was neurologically intact, as most of these patients are, and didn't want to have anything to do with surgery at all. So we followed him along, and here he is at 15 months post-injury. He's completely asymptomatic, but you can see on his flexion extension films that his odontoid is still mobile. But he's very happy with his result. He says, yeah, it's great because I do my sit-ups every morning and I put my hands behind my head and I pull my head forward to get myself to do my sit-ups. And he has had no untoward events related to this odontoid non-union. So certainly every odontoid that fractures in the elderly does not need to be fixed. And when the AO group did their geriatric odontoid fracture, they did a subgroup analysis of 50 patients who had non-unions. Of those, 22%, 11 required surgery or underwent surgery. And if you read the paper carefully, it's hard to understand exactly what the indications for surgery were. So many of these patients, it's unclear whether it was just motion or pain or very few people ever show up with neurologic problems. But this paper showed that there was really no difference in the outcomes between the patients who had union and non-union. Likewise, Bob Molinari looked at a series of patients 25 patients who had displaced odontoid fractures and compared them to 30 patients with really minimally displaced fractures treated in a rigid collar for 3 months. And they had over a year follow-up. Clearly, the fusion rates were higher in the surgical group. But if you look at patient-reported outcomes, NDI, VAS, and satisfaction, it turns out that the collar group actually all had higher outcome scores than the surgery group. So I think that we need to look at elderly odontoid fractures and be a little bit careful in who we choose to operate, because not every single one of them needs surgery, certainly. Halo immobilization, which was the traditional method of immobilization, has really fallen out of favor. Not only do we see a high suit arthrosis rate, but especially in the elderly, the complication rate from wearing a halo is quite high, and it can lead to many, many problems. So I think more currently, when we see elderly odontoid fractures, if we're going to treat them non-surgically, we use a rigid cervical collar by and large. And if we can't maintain reduction in a rigid collar, then that may be something that pushes us over to consider surgical treatment. The odontoid screw has been popularized for the treatment of type 2 odontoid fractures. It's a nice way of treating these because it really is fairly minimally invasive, and it's done through a very traditional ACDF type approach. It requires 2 C-arms, but it is it's simple to do. You need to have a fracture that's reduced. You can't fix a unreduced fracture. Osteoporosis may be a relative contraindication to this technique, although every elderly person who has an odontoid fracture is somewhat osteoporotic by definition. Most importantly, you have to be able to get your hand in an appropriate position to get the right trajectory for the screw. And if someone has a barrel chest and you can't drop your hand appropriately to put the screw in appropriate position, then it can't be done. And also, as we see many odontoid fractures that are associated with C1 ring fractures, you have to know that the C1 ring is stable at the same time. So it's not appropriate to be done in patients with C1 ring injuries in conjunction with their odontoid fracture. The reverse, and you have to look at the obliquity of the fracture line. What we call a reverse obliquity fracture would not be appropriate because putting the screw up from below would pull the fracture anteriorly and displace it. Whereas if you have the opposite angulation, the screw will be going at right angles across the fracture line and compress it. But if your patient looks like this gentleman and has a very short neck and a very big chest, being able to place an anterior odontoid screw is essentially impossible. But this certainly can be done successfully. And here's just another literature from clinical spine surgery in 2011, a retrospective review of 43 fractures. And you can see a mean of 81 years. So they're dealing with elderly patients and an average displacement of 5 millimeters. But 36 of the 42 healed. So that's a fairly good healing rate, 85%. The study didn't have any health-related quality of life data to support how the patients did clinically, but on a radiographic basis, you can get patients to heal if you can get their fracture reduced and you can get it stabilized. Posterior C1, C2 fusion has become kind of the workhorse, at least at our institution, for most of the elderly odontoid fractures that we see. This was initially described by Gelb back in 1994, although most people call it the Harms technique. Dr. Harms wrote about it in 2001. It is favored because you don't have the same anatomic limitations that you have from the anterior approach. You can do this on almost anyone. The fracture itself does not need to be anatomically aligned. You can do this with displaced. You can do this with people who have had hardware failure in the front and even in the face of osteoporosis. From an anatomic standpoint, this is a prosection of the upper cervical spine, the base of the skull, the C1 arch, and C2. And many people worry that we know that the vertebral artery is in the neighborhood. And if you look here, you can actually see the C1, C2 joint. And that's can be difficult to visualize in surgery sometimes. But if you see the C2-3 joint, you know that the C1-2 joint will line up with that. So as a good, easy anatomic start to figure out where you need to be, if you see C2-3 and come straight up, you'll find the C1 lateral mass. The C2 nerve root exits directly under the arch of C1 and has been a topic of infinite debate about what to do with it. Some people will section it and get it out of the way. Other people will retract it, and each has its proponents. Some people say if you section it, the patient's less likely to have occipital neuralgia postoperatively, but it seems hard to just cut a nerve like that. We've been interested in the C1 anatomy for quite some time, and we published a paper, among others, back in 2009, and we coined what we call the working window. So you have this, we like to put the screw directly into the lateral mass of C1 as opposed to through the arch. Some people will use a through the arch approach. We go underneath the arch, feeling it's safer because you stay further away from the medially traversing vertebral artery, which is a little bit difficult to see. However, at times this working window can be quite small. You can see if you take the C2 root, it really opens up the window and allows you to work underneath the arch to put your C1 screw in place. I actually like to do this more or less with the image intensification. So if you can't your image so that you get basically an open mouth odontoid view of the upper cervical spine. So here's the odontoid, and you can see the lateral mass of C1 and the lateral mass of C1. On this side, you just put a burr right at the inferior portion of the C1 lateral mass on an AP fluoro and make a small hole. In the same spot, you put your drill, and I use a hand drill, and then under lateral fluoro, you can drill right up into the lateral mass of C1. You want to aim more or less for the middle of the C1 arch, but the drill should really stop at the anterior border of the odontoid, because you're off center. If you go all the way through into where the arch is, you'll actually be out the front, and the internal carotid artery and the hypoglossal nerve live in that neighborhood. So really, your screw should not go past the anterior border of the odontoid. But we put the screw up, and then in the same lateral fluoro, we put the screw in C2, either a pedicle screw or a pars screw. However, the anatomy will allow you to do that. That really is probably the biggest rate limiting step in fixation in this area. We can almost always get a screw in C1, but occasionally a pedicle screw in C2 is not possible because of a large vertebral artery or a medially placed vertebral artery. And you have your option of doing a pedicle screw, a pars screw, or you can do a translaminar screw across C2 to the other side and get excellent fixation in that way. And then once we have one side done, here again, you can see the lateral mass of C1 quite clearly. The occipital cervical joint is here, and you just put that screw right up. So what about outcomes from surgery? Well, certainly one of the most quoted studies and one of the larger ones is the AO study from 2013. They had 159 patients. 2/3 had surgery. A third of patients were non-operatively treated. This was not a randomized study. It was surgeon choice. But the surgery group had better function, less pain, lower non-union rate, and lower mortality. There may have been some selection bias that clouded those results. There's a meta-analysis that I thought was quite good because it had over 1,000 patients in this meta-analysis, 21 publications. And they found in this meta-analysis that surgery actually improved survival for these elderly patients. C1 and C2, posterior C1, C2 fusion had the highest union rate, but odontoid non-union was not necessarily associated with worse functional outcome. So overall, what does literature tell us? Operative treatment provides a better fusion rate than external immobilization. Yet for younger patients, less than 45, certainly in minimally displaced fractures, a halo, which they should tolerate better, or a rigid collar can be as effective as surgery for healing. But in older patients with displaced fractures, operative management leads to the highest fusion rate. However, insufficient data exists to tell us really about clinical outcomes. So what do we do more or less at our institution most of the time? Well, non-displaced geriatric fractures generally get a hard collar. If the patient can't mobilize, has a lot of pain, we'll consider either anterior or posterior fixation, most of the time posterior. If the patient has dementia, has minimal functioning, really low demand, we often just place that patient in a soft collar, not going to put them through a big surgical procedure. Loss and reduction in the collar, indicating non-union or instability, will be much more strongly considering of a posterior fusion. And symptomatic non-unions, the salvage there is really a posterior fusion. And for many of the displaced, I think we're moving in a direction where if we see a displaced geriatric fracture, we are at an institution where our ability to get an 80-year-old or an 85-year-old through that surgery is pretty routine anymore. The surgery itself takes maybe an hour, maybe an hour and a half. The setup usually takes longer than the surgery itself. And with a good anesthesia, we can move that surgery along pretty rapidly, and patients tolerate that fairly well. So that's kind of my overview of odontoid fractures. And at this point, I'll pass it off to the next speaker. Steve, do you have any comments or?
No, I think, Dan, that was a great overview on it's actually a very cumbersome subject because there's just so much data out there, and you've really sort of been able to deconstruct that and help everybody understand at least what our algorithm is at Shock Trauma. So thanks for doing that. I think we should jump into the cases if you agree. I think we all learn a lot more about, going through these cases. Dr. Lara is one of our spine fellows this year, and she's going to talk about a case that I think is common to us all. So Nina, we'll give the floor over to you.
Nina, you're muted.
I think she is muted.
Yeah, can you guys hear me okay?
Yep.
Yeah, now
Go ahead, Nina. Now we hear you.
Great, thanks.
Yep.
Okay, so first case we'll talk about is 100% displaced odontoid fracture. So let me just move this slide here. So an 80-year-old female on Pradaxa for atrial fibrillation status post mechanical ground level fall. She sustained, her only injury she sustained was a displaced type 2 odontoid fracture. So again, past medical history, she has atrial fibrillation on Pradaxa. She has coronary artery disease, status post multiple stents and hypertension. Past surgical history, relevant surgical history, she has a remote history of a T12 fracture, status post kyphoplasty. And then her exam was overall normal. She was 5 out of 5 bilateral upper and lower extremity strength. There were no neurodeficits. So you can see here, this is her initial CT scan here, which shows a type 2 odontoid fracture. Again, she's lying down. You can see here, this is a cut of the C2 level. You can see she has a large vertebral artery on the left side. For standard x-rays, we always get uprights in determining whether it's an operative case or not. And you can see here with her upright films, open mouth lateral, and AP, you can see here that her odontoid fracture significantly displaces posteriorly in a collar. So again, we have a displaced type 2 odontoid fracture. And then I'll kind of wait to go on to the next slide to show you what we decided to do.
Yeah, so thanks, Nina. I think this is once again, this is a really typical example of octogenarians that we all see that have a ground level fall or have multiple medical comorbidities. And if you go back to her CT scan and her original, injury pattern, what you'll notice is that, her odontoid looks sort of very minimally displaced. And because of her medical comorbidities, I think we could all make an argument to treat this non-operatively. Dan, I think when you look at her upright x-rays, or excuse me, when you look at her pre-op x-rays, is there anything that you can use from a predictive analytics to tell you that this thing is going to displace or not? Is any clues at all from your standpoint?
Do you mean from these films or from the CT scan?
From the CT scan.
Well, I think one of the things that's always interesting to me, and I don't know if I have real data to support it, but you see that she's got essentially an autofusion of C1 and the PEG, right? So so I think that means that there's she's got a much bigger lever on it. She's almost fused to her occiput at the clivus. So I think the lever arm of this fracture is really big. The head acts as such a big mass object, and then you add into that the fact that she's fairly kyphotic, so she has to extend her head to see forward, and I think those two factors together really predispose her towards posteriorly displacing this fracture.
Yeah, the other thing that I look at too is the C1, C2 joint, and sometimes that looks like there's a rotational injury to the joint itself, and that could also give you some clues as to this is not only a fracture that you're dealing with, but you're also dealing with a tear of the capsule of C1, C2 and a rotational component to this injury pattern, and that may give you some clues that this fracture will displace like it did when we got her upright. So if Nina, you go back to the upright x-rays, and if you can point out, because sometimes it's hard, in the webinars to come across, but if you can outline the odontoid for us, you can see that it's completely displaced, when she stood upright. And I think this was the clue that, that allowed us, to have this discussion with the patient to talk about, a posterior directed fusion procedure. I think this is a hard patient because she's osteoporotic and because she's completely displaced to even discuss an odontoid screw. I think that would be a very large stretch in this patient. But if you can go right to the x-rays, the post-op x-rays, we can go through the post-op, what we did. In this case, I think Eugene Coe is on. Eugene, when do you determine, your type of fixation? I think Dr. Gelb already alluded to C2 as the rate limiting step. How do you decide between this technique, doing a C2 pars, pedicle, translaminar, going an extra level? Any thoughts on that, Eugene?
Yeah, kind of the decision making is looking at the axials to look at what your window is to navigate the C2 screw. I think the technique that I predominantly use is a what they call a parsicle screw. That was recently described in one of the spine journals, but it's a combination of going through the pars, and the tip of it is actually going into the pedicle. But your rate limiting step for that parsicle screw or pedicle screw is actually the vertebral artery and your window for the pedicle with the vertebral artery. And then the second thing is when I look in trying to determine whether I need to extend the fusion down to C3, I want to make sure there's no osteoporotic bone, or if there is, how good my fixation is with the C1, C2 screws. And if it's poor, then I actually extend the fusion down to C3 to get better screw fixation.
Yeah, I think that was the thought process in this case. She had a ectatic vertebral artery that was in the way on both the left and the right. She's osteoporotic, and she had fairly significant arthritis at 2-3. So getting an extra point of fixation was just merely for that, to get another point of fixation, but safely, navigate your screws into the correct position. Dan, Gelb, any role, is the Magrill technique a transarticular technique? Is it dead? One of the audience members sort of asked about the Magrill technique. Do you ever use that technique anymore? Or is it?
I haven't done transarticular screws probably for, it's got to be since we've been in Maryland, so it's almost 20 years. There's about an 8% risk of vertebral artery laceration or impingement with Magrill screws, and essentially zero with this, if you're careful with your C2 screws. So we've really given up on that technique. I mean, biomechanically, it was great technique. It can be difficult. It's difficult to do. And I suppose if you were using navigation, it's something you could entertain. We don't do any navigation for these. We do these all with fluoro and freehand. I've not been doing any Magrill screws for the longest time.
Can you describe the your C1 technique? Because yours is a little different. I tend to dissect and work side to side and deal with the plexus and put Surgiflow. I use a lot of Surgiflow and Fibrillar to get hemostasis. And then I go to the other side. And by the time I come back to the initial side, I typically will take a Penfield dissector and pop it into the joint, and it gives me a nice exposure to C1, and I put the C1 screw in. You do an alternative technique with a burr under flora. Can you describe your workflow, and are you taking the C2 nerve root, or are you just putting the burr right through that region? What are you doing?
Yeah, I use a 3mm cutting burr, so it's fairly small. You have to make sure when you do these cases that you flex, you got to flex the head down so that you open up the window between C1 and C2. I think one of the mistakes people make is they kind of have people too extended, and it makes it very difficult to put the C1 screws in. But if you look at and I do this all pre-op, before I even make an incision, I got to get this all set up so I know I can do this. I look at the lateral, I look at the reduction, I look at the space between C1 and C2, and then I get my open mouth view. Like I flip it right to an anterior posterior, and it's usually about 10 or 15 degrees off vertical to get a true open mouth view. And then when I do my dissection, and then I I bring the C-arm in, and under AP C-arm, I just slide the burr right under the C1 arch till I hit the lateral mass of C1. Just like you'd feel it with a pen field, I feel it with the burr. And I confirm with the C-arm that I'm in a spot that I like. And then I just make a small, I just go through the cortex posteriorly. And I left to right that image so I know exactly where I was. And then I take it out and I put a hand drill. And I never even see the lateral mass of C1 directly. And I don't really dissect out the C2 nerve root, and it doesn't bleed because you're not trying to pull out all those veins. And it's really a very easy thing to do and almost bloodless.
Is it hard to find your pilot hole after you drilled it?
I've not had a problem. I mean, I think you just have to be, you gotta keep your workflow, right? You put the burr in, you hold it there. I don't turn my head. I reach my hand out. My scrub tech hands me my drill, right? And as I pull the burr out, I put the drill in. So, I'm kind of watching the whole time. And as I said, I have that left to right fluoro. I just take a quick fluoro spot and I can see that it's in exactly the same spot. And, you can feel that you're in bone. I mean, you have resistance to it. And so I've not had a problem with missing.
How do you control the head in such an unstable fracture? Do you use a Mayfield? Do you try a closed reduction to get better position first? Do you use axial traction, biplanar traction? I mean, what's the technique that you guys like?
We put them in a Mayfield head holder. And as I said, we flex the chin down to open up that posterior area. And then if you put them in reverse Trendelenburg and tape your shoulders down a little bit, you're essentially putting traction on the fracture. And most of the time, you can see here, I mean, it lined up anatomically once you got it fixed.
Yeah,
you can manipulate the fracture. Once you have a screw in C1, you can manipulate the fracture with the screws because you now have the peg goes with the C1 ring. So you can actually reduce it if you have to. But even if you leave it a little unreduced, I think it's just fine.
Yeah, I was going to say, it probably doesn't matter if you even reduce it. I don't sweat about if the reduction doesn't look as good as this. I don't even sweat it. It's not that I don't care. It would be great if they all look like this, but we've definitely left these odontoid pegs not in the perfect position. And I'm not aware of any literature that says we have to reduce them and they do better. Or more importantly, there's any neurologic concern. So yeah, I position them supine on the table first and then get them in the Mayfield, really flex them down and sort of translate them down. So it opens up that window that Dan was talking about. And then we sandwich and flip them on the OSI table. I think it's a very, very controlled way of doing it. And then it's unbelievable once you do their final positioning and get an x-ray on them that they look much like this and it becomes a sawbones technique.
I find the MPR for this type of fixation is very useful just to plan on the CT scan exactly the axis of the screw, especially for C2. And I've seen cases, as a matter of fact, where the Magyar screw was safer than to put a pedicle screw in C2 because it got you out of the vertebral artery because you had a very, very steep ascending trajectory. So if you mimic perfectly you're planning on the MPR, when you're going to put the screw and you exactly put it exactly the way you've planned it, it's safe, and I think the Magyar screw can be safe. You can even cheat a little bit and go very, very on the top of the pass of C2, and you get into the joint. So it's not perfectly a Magyar screw, but it's a betweener between the pedicle screws and a Magyar screw in some cases. So I think we have to get all the options, plus also the translaminar screw if necessary, if there is no other option. But I think the MPR, when you're planning your surgery, is invaluable to get exactly where you're going to put your screws in.
Yeah, that's a great point, Vince. The screw's not dead. You really need to understand the craniocervical anatomy in order to safely position these screws, as you know. You brought up real fast before we go on, but I think it's worthwhile talking about a translaminar screw I actually don't like it. I don't know. I'd love to hear Eugene's thoughts. I don't like it because it requires me, if you believe that fusion is important, as opposed to immobilizing the area and letting the fracture heal, in order to get that area to fuse, you really have to do a direct fusion of the C1, C2 joint. And that could be bloody. It could be a big dissection. You may have to sacrifice the C2 nerve root. The space in between the C1, C2 joint, is a very small joint. It's hard to pack the bone grafting material. So I think it's almost a futile effort in my mind. My concern is when you do a translaminar screw, although the fixation is tremendous, you need a fusion surface. So if we're going from the occiput down to C2 or C1 to C2, as opposed to C2 down to the subaxial spine, I don't like it because of those fusion concerns. Eugene, any concerns about that, or am I crazy?
No, I agree with you, Steve. I always worry about what kind of grafting across the C1, C2 lamina would be. And you kind of obligate one side if you use a translaminar screw, and it's hard to decorticate that and not lose your fixation for the translaminar screw. The other thought process that I've had, I kind of get concerned about this, is I've seen different techniques described of how to get a C1, C2 fusion other than going into the C1, C2 joint, whether it's using kind of structural allograft. I've learned back in Emory using actually posterior rib as a structural allograft to kind of buttress between C1 and C2. I typically don't do it now. I use kind of morcellized allograft for that region. And sometimes if it's really osteoporotic, I'll try to harvest iliac crest.
Yeah, that's a really good point to bring up, what your choice of bone grafting is. I can't remember the last time for an acute fracture in an octogenarian elderly person, even in a young person with a displaced type 2 odontoid fracture. I typically am using local spinous process bone from C2 and an allograft bone and demineralized bone matrix. Only in the face of a non-union where somebody's proved that they haven't healed it will I go to the iliac crest, but only in those circumstances. Dan, what is your go-to graft?
Crushed cancellous allograft.
Yeah. Anybody else on the participant panel? Anybody else using iliac crest? Are they always going to the crest? Is the crest antiquated? Is it crazy to go to the crest?
It's crazy.
I use it when I do occipital cervical fusion. I go to occiput.
No, Sasso just said it's crazy. It is
crazy.
Great.
All right, Steve.
Yeah.
I love the presentation. It was outrageously great. I love your comments, but I have to disagree about direct fusion of the C1, C2 joint and using laminar screws. That's a perfect case of using translaminar screws. You don't have to go to C3. You're going to get screws that are twice as long as the probably 12, 14 millimeter screws that you put in the pars of C2. You're going to get 26 millimeter screws in the lamina of C2. You're going to get great fixation at C1. And you've already dissected out this, how I put C1 lateral mass screws in. I've already dissected out the joint. You're already in the joint. So it's so easy to just put a burr in there, and then you put BMP and some, I use Mastergraph, some tricalcium phosphate.
You're shoving a little BMP sponge in there? Is that what you do?
Exactly. Exactly right. It's so easy. You've already exposed the joint. You've already mobilized the C2. So I do it a little different than Dan. I mobilize the C2 nerve.
Afraid of overgrowth?
Pardon me?
Afraid of overgrowth with the BMP?
I'm not. I'm not. If I decompress the canal, I will not use BMP posteriorly. That's a whole different subject. But if I'm not decompressing the canal, and this I wouldn't. This is a type 2 odontoid fracture. I've done this 5 bazillion times. I'm not going to decompress the canal, so I will use BMP in the joint, and I've not had one fail yet. Yeah. I've not had a pseudoarthrosis.
My biggest fear, and then I guess we can move on. I hear it loud and clear because you're saying you're doing all the work. You got it all spilled out in front of you. Yep. Why are you going down an extra level? I don't know if it matters. I'll just play devil's. I don't know if it matters in an octogenarian, to go down an extra level.
Right.
But my concern would be, God, it's bloody. It's hard to see. It's
not. Here's the thing. You have to know how to mobilize the C2 nerve. If you know how to mobilize the C2 nerve, this is a bloodless operation to move the C2 nerve back and forth and expose the C1, C2 facet joint.
What's the
If you
secret,
don't
Rick?
mobilize the C2 nerve, you're right. It's a bloody mess. It's horrible.
Yep. Yeah. Any tricks that you have to mobilize the C2 nerve root that you can share with us before we move on? Next case.
Yeah. So there's a fascial component that overlies the C2 nerve where the venous plexus is under. You have to expose that fascial component. You have to get through the fascia. Most of us orthopedic surgeons are not comfortable with that. We're not comfortable exposing neural structures, especially at the occipital cervical junction. You got to learn how to do it. Do it in cadaver a few times, then do it in real life. But you have to get through that fascial component and then see the venous plexus, and then it's super easy, really straightforward.
So the other option is, so thank you, Rick, for speaking out in favor of translaminar screws. I think it's an essential thing, and in your hands, in our labs, you make it look so easy. It's amazing. But I do want to point out for the Atlas screws that you don't have to take the C2 root. You can do these so-called palm screws, posterior arch lateral mass screws. We published on those. There's several authors who published on those. You have to be willing to put the Penfield forward, just like what Rick said, under that small fascia on top of the Atlas arch into the sulcus. You don't have to dissect the vertebral artery out, but the Penfield 4 will guide you straight onto the lateral mass and protect the vertebral artery as you drill down into the true lateral mass. So you basically sacrifice the arch in very thin patients, but it keeps you out of that whole C2 mess, and you don't have to do anything. I use a shank screw there so that there's no erosion potential. So just wanted to put a pitch out for the palm screw to not massacre the C2 root. Thank you.
Excellent. Thank you, Jens. So why don't we move on to the next case? It's a little different that Peter Cohn has. It's in a younger patient, so we're going to shift gear. So Pete, you want to go through this case?
Yeah, absolutely. Thanks. So as Dr. Ludwig mentioned, this one's going to be a little bit different flavor. Let's see, I don't have the arrows on my screen. There we go. So this is a 30-year-old male who was involved in a motor vehicle accident and presented with neck pain. He is a smoker, but otherwise healthy. And on his presentation, he had no neurologic deficits, no radicular pain or anything like that, and really no other injuries other than his cervical spine. So here are his initial CT cuts. First, just a midline sagittal demonstrating type 2 odontoid fracture, and also some kyphotic deformity here between C4-5. If you look at the coronal reconstructions of the odontoid, you can see that it is a type 2, minimally displaced. And then if we move on, I added some cuts of the facet joints just to show that there was some anterior displacement of C4 on C5 with some subluxation of the facet joints and a unilateral lateral mass fracture on one side. I believe that was the right. So we actually did get uprates and a collar in the trauma bay, which do show that anterior displacement of C4 on C5, and really no displacement of the odontoid fracture, and an open mouth view as well. So here, two different injuries in a younger patient, higher energy mechanism, but C4-5 facet subluxation, so basically a fracture dislocation at C4-5, also with a minimally displaced, non-displaced type 2 odontoid fracture. I think there's a lot of different ways we could go with this in terms of treatment, and maybe I'll open it up at this point.
Yeah, so I'd love to hear from, maybe we could start with Ricky or Jens and talk about, maybe deconstruct this a little bit. A little off subject, but he has a cervical facet injury. I'll give you a little bit of the details. He was displaced about 3.5 millimeters. He had local kyphosis. His facet fracture was approximately 50% of that of the contralateral side, with an associated non-displaced type 2 odontoid fracture. Jens, Ricky, any thoughts on this?
Does he have a radiculopathy with the facet fracture?
Unilateral. Correct.
Yeah.
Yes, I'm sorry. He has
So,
a unilateral radiculopathy, no objective weakness.
So that's going to be a problem. That's a big, that's a big fracture component that he has there, and the studies show that's probably not going to do well non-operatively. I think that's something you're going to really need to consider. Now, the odontoid fracture, completely different than the last case, right? And I think he's a young guy. He's going to have good bone. It's non-displaced. An anterior odontoid screw is super easy. It's elegant, really nice to do. I would probably consider that anterior odontoid screw, and then fix his facet fracture, decompress his C5 nerve.
Hey, Rick, what's the smallest odontoid fragment you'll try to, because I remember this case came through and I looked at that and I said, man, that's a pretty small piece.
Yeah.
So what's the rate limiting step
So-
in how small a piece you can skewer?
All right, that's a great question. And it's really important depending upon how you do your lag technique. So if you use a partially threaded screw, some people call it a lag screw, that's a huge deal, because sometimes the threads are too long to pass completely across the fracture. And I've been in a position where I didn't have, I was in a bad position. I had to actually cut the tip of the screw off to use it. So I don't use partially threaded screws. I use a fully threaded screw and set up a lag technique where I over drill the C2 body fracture and then just tap the odontoid peg. So it doesn't matter how small that fracture peg is, you know, how small the odontoid peg is, because I don't use a partially threaded screw. Does that make sense?
Yes, yeah, absolutely. That's great.
Yep. So Pete, why don't we show what we did so we can get to the next case as well?
Yeah. So essentially, yes, that is what we did. We did an ACDF at C4-5 and then used that approach for our odontoid screw. We used a 4.0 Synthes, basically cannulated screw. So we didn't have any screws with shorter screw thread length, as you mentioned, than the one we have here. But we did over drill, proximally to us, distal to the patient. And probably this gentleman, he wasn't barrel chested, I would say, but he was young and thin and strong. And they actually got a CTA to look at a vertebral artery injury. So we actually had a CT to really nitpick where our screw placement is. And we had our angle with the drill really resting on his chest, but unfortunately that was that is just the angle we could get. And these were his post-op, and then actually we saw him a couple of weeks later and he was doing pretty well.
Yeah, but I think if you're going to criticize the screw placement, you could say, well, the angulation could have been more vertical, and we could have done a better job at lagging it down. This could actually be a non-union maker, because we didn't suck the fragment down, even though we tried, and it looked like under fluoro, we had a good reduction. You sort of get fooled with fluoro, and this may be one of the benefits of intraoperative CT, like an O-arm, bringing it in, because perhaps we would have redone it or tried to get it a little bit better, of a lag technique.
Steve, I tell you, the problem, I've seen this so many times, is the entry point. The entry point actually needs to be within the disc space. You have to take a part of the annulus out to get into C2, C3 disc space. The entry point here was a little too anterior, so you can't get that vertical shot across that fracture.
Yeah,
and that's why you have a shallow trajectory.
Yeah, we usually take a bovie because it's the same approach, and we put the bovie into the disc space and sort of turn it on to sort of melt away a little of the annulus. The other technique that we've used to get the trajectory is actually with a Jamshidi needle. And we actually put the Jamshidi needle into the disc space and then drive it in proximally just a little bit. And then that gives you the trajectory, in a very fixed fashion under the AP, and you could just drive everything in under the lateral. So it's sort of, if you don't have access to two C-arms, which can be very challenging to get, at least at our institution, that's one way of getting through it if you're not using an image-guided system.
Steve, has anybody used navigation to help with these?
There's definitely reports of people using it. We have it at our institution, Rick. We just don't use it. We have a robot. We have all the gears, and It just doesn't seem like the juice is worth the squeeze, although you can argue in this case, we could have probably done a better job.
I use it, Rick. I use it to navigate the AP so I don't have to use biplane fluoroscopy. So I navigate basically the AP view and I do a live lateral.
Yep.
The reason that I asked is that, you know, all you guys are masters at doing it. You've done a zillion, Dan's done a zillion. And I'm thinking of the fellows that are on the talk here, that unless they go to a place where they've done a lot, I mean, it's hard. And even as Rick just talked about dissecting the fascia over the C2 nerve, I mean, that's something that, you know, even when I was way back when doing trauma, I was never taught to do that. So I'm trying to think how you can make it easier for the person that doesn't have a vast experience.
Yeah, probably to your point, the image guidance system is probably a good way of getting through your learning curve.
Can I ask a question?
Absolutely.
And it's more focused on the C4-5 injury. So the C4-5 injury with the facet fracture subluxation is a posterior injury. So there's a ligamentous component with it as well. Was there any consideration, number one, to going posterior to decompress the nerve and then to stabilize it posteriorly? And then number two, are you happy with the amount of lordosis that you got anteriorly?
Yeah, I think, you know, there are people that have sort of these high mechanism of injuries and a true discoligamentous structure with a traumatic disc herniation. If you get good fixation, good correction, you could potentially treat them all from the front. We really try to avoid doing 360s if we can. Kyphosis is not good. If you look at, I don't know where can you bring up the post-op x-rays that you have?
Got
In his follow-up? I think he is kyphotic there, Scott. And I think his overall, he's got a degenerative disc at the level below. Mm-hmm. But I think I don't know if we necessarily have to restore his alignment like a deformity operation. I think our goal is to just put him back where he belongs.
Sure.
And just keep
Thanks.
him.
Thanks.
You want to move on to the last case, so?
Yeah, we'll finish up with elderly patient presented to our institution with a fall from standing height, 73-year-old on anticoagulation for AFib, otherwise had no complaints and neurologically was intact. These are her upright cervical imaging x-rays that we got. AP lateral and open mouth, which show appropriate alignment, but a CT was obtained to better characterize the fracture as well as alignment. A very low type 2 with possibly some extension into the left-sided C1-2 joint. Overall, very well maintained in terms of alignment on the coronal, sagittal, and not a lot of rotational movement that we could see. Patient was treated with conservative management, a hard cervical orthosis, and in 3 months presented for evaluation with severe posterior neck pain. And at this point, a repeat CT scan was actually ordered. This is the repeat imaging that the patient had at 3 months status post-injury. You can see significant evidence of a non-union with erosion of that fracture site. The alignment actually looks appropriate. There is some slight translation posteriorly. However, the overall alignment has not had significant displacement or angulation at that fracture site. So to discuss, the patient is now 3 months after non-operative management, really without any improvement, significant posterior neck pain, neurologically intact otherwise, and operative management was discussed with the patient. So we can pause here for a moment.
So at the end of the day, we have what we're presuming is an ununited odontoid fracture, 3 months, horrible craniocervical discomfort and pain. Couple of questions that came up in the chat room that I saw that we could talk about. Any role for a CTA in these patients before you're doing craniocervical work? Do we need a CTA? Dan, Gelb, I think this is your case. Any
This is
thoughts?
my case, yeah. Well, I think most of the time with a good fine cut CT scan, you can see the vertebral artery in the place where you need to see it, which is the C2, lateral mass, and get a sense of whether there's a patulous or a large vertebral artery. I think if there's any question, I wouldn't hesitate, but I don't think it's mandatory every case.
We have one of the questions from the audience was, how do you know that, she has a chronic degenerative neck, she had a previous couple level ACDF. How do you know the pain generator is coming from that? What was your thought on that?
Well, I mean, first of all, she was completely asymptomatic before her fall, right? So she had this previous surgery. She wasn't having any, at that point, was asymptomatic, and then she fell. And she had that very typical, most of these people get kind of a C2 root syndrome. So the pain is very characteristically retroauricular. They get pain back behind their ear in the petrous portion of their temple bone. And that to me that's the C2 nerve root, and that's where she hurt. So I had very little, I wasn't really worried that this was anything other than an instability of C1, C2 from a non-union. Her presentation was so characteristic.
Got it. So can you bring us through what you chose to do?
Okay.
Find the posterior C1-2 arthrodesis on this patient. Actually did have a CT to evaluate for her vertebral artery, which didn't have any anomalous pathway or ectatic course. And using the technique Dr. Gelb described in terms of obtaining a C1 and C2 instrumentation with fluoroscopic guidance, using an AP and lateral imaging, we did obtain a PAR screw as well as lateral mass screw fixation for this.
What was the choice of bone grafting material for this, Dan? Is there a role for iliac crest in a chronic ununited odontoid at 3 months, or are you still using allograft bone?
I'm still using allograft. I mean, I think you can certainly make the case, right, that if this is someone who's really not a good bone former, and you want to do everything you can, I would probably favor what Rick talked about. I mean, if I was going to, rather than go to a crest and give her another incision, the bone down there is going to be just as osteoporotic and kind of crappy as you're going to get. If I really was, before I laid my rods in, you can come right up to pars of C2 and get right into C1, C2 joint. And if you want to take a small sponge, a little piece of the sponge and stick it in there, I'm sure you could, that would probably, and then put the rods in afterwards. I think that's a great idea. Better than going to the crest.
Yep. And then
I didn't do that in this case, but that would be an option.
Post-op immobilization, she's been in a collar for 3 months, right? We just fixed her odontoid. Are we keeping her in another collar for another 6 to 12 weeks? Like, do we need a collar? We just fixed it. What's the deal with collars?
No, she's going back into a collar. She's going back into a collar in my hands for at least probably a month. But that's just, there's no science there. It's just kind of makes me feel better than her. I mean, I think that's the conundrum, right? For every one of these patients who comes in has a minimally displaced fracture, and you say, oh, you don't want to, nobody wants to have surgery. I'm 80. I don't want to have an operation. Then they're in a collar. And then you start, and for 3 months, and they have pain, they start all over again. If you just fix them at the front, done.
Yeah. Yeah, no, I would feel the same way. We typically do. It may be, we typically say, well, we're treating this horrible fracture dislocation, in the thoracolumbar spine or even in the cervical spine, in the thoracolumbar spine, and we don't brace anybody. And then we do a fracture dislocation in their cervical spine, and we get good fixation as well, but we keep them in a collar. Craniocervical work, we tend to keep these patients in the collar. I do the same thing. I don't know if anybody else immobilizes these patients after they've operated on them. I don't know if there's any data to support it either.
Jens, you're shaking your head both ways. What are you trying to say?
You did a beautiful job. Absolutely gorgeous. Why would you want to atrophy the muscles further? Trust your work, trust the nice bone grafting, and go from there.
So Jens, no mobilization. You fix them, you're done.
Done. I mean,
I agree.
It's really nicely done. And again, obviously there's a medical legal reality. And if we have a completely non-compliant patient, we have to protect ourselves. So I can't say it categorically, but usually, especially if I have a post-out of CT and I get a post-out CT scan still on all those patients with 3D imaging, trust your stuff. It works like a charm. And that's that. So, congratulations, nice case.
All right, we're gonna trust our stuff. We'll end on that. I
It's
don't see any
beautiful.
questions in the chat room.
Great
But Steve,
talk.
you guys did a great job.
Thank you, Dan. Beautiful initial presentation. And Steve, you're a great moderator and your fellows did a good job with the cases. So thank you, guys.
Thank
It was a pleasure. Thank you, guys. Thank you.
Stay safe.
Good night, everybody.